Hey there, listeners. Welcome back to the Let's Get Oral podcast. In this episode, we continue our Totality of Care series by sharing a conversation between Nathan Bryan and Gina Pritchard, the Vice President and Medical Director at the Integrative Dental Medicine Scholar Society. Gina Pritchard is an acute care nurse practitioner who specializes in cardiovascular disease prevention and treatment. So without further ado, here's our conversation with Dr. Bryan and Dr. Pritchard at the 2024 Totality of Care Symposium.
Let's get oral. Let's get oral.
Hey. We're at Totality of Care still in Knoxville with IDM and LMU, and I'm here again with Dr. Nathan Bryan, but this time we have Gina Pritchard with us, who's an incredible doctor of nurse practitioner, but she is with the Prevent Clinic and has some incredible work to talk about. But first, she's going to interview Dr. Nathan Bryan, and she has some really specific questions that I think are relevant for all of us. So.
Thank you. Thank you so much for having me. Yeah, we are. We're on the hot seat. You are. We could do rapid fire if you want.
First, I just want to back up and say, what is your specialty, just for the record, and kind of give a little bit of background about yourself, because we know that Nathan Bryan has like all the nitric oxide specialty, but you have a very relevant practice that goes deep in this space. And so
So my board certification is as an acute care nurse practitioner, meaning hospital work, urgent care type things. And most of my career was in the critical care unit, specifically the coronary critical unit, where everyone with a heart attack would come in, stroke, we needed to rule out having chest pain, are they having a heart attack, are they not, that kind of thing. And so people would come in, I say it's a steady stream, a never-ending steady stream. There was never a day that we're like, maybe we won't have somebody come in with a heart attack today.
Goodness.
It was just continuous.
Yeah.
But loved that world and still do. But about 2005, I had like it's tragedy every day there. But this one hit me particularly hard because, for one, I'd already started to think, once people come in and have a stent, even if they haven't had a heart attack, but especially if they've had a heart attack, their life changes. And most concerning is they will be back. Like, very seldom did we never hear from somebody again unless they moved or whatever. They needed another procedure or at least another look at the heart. So I was already thinking these things about the same time that I realized I had the worst family history ever. This is going to happen to me if I don't figure this out. And then I had a 45-year-old gentleman come in with the worst presentation of heart trouble, sudden cardiac death, which a third of all heart attacks, the individual does come to the emergency room fine this morning, and then checking out at the grocery store or working their day like normal, and just they drop. And unless somebody around knows CPR and takes action quickly, that person will not survive long, as you know. So that happened to this gentleman, but he was revived and came into the emergency room. And that day also we'd put the most stents in anybody's heart we'd ever done. So we were in the nurses' lounge just talking about all the events of the day. And it was like, how many stents are we going to put in somebody? And how many times are they going to come back? And then, of course, about the sadness of this gentleman. And then what finally sent me home just crying, saying, I have to figure this out. In addition to all of those things are when I went out to the waiting room to talk to his parents, they were both regular clients of mine that I would see in the cardiology clinic and see in the hospital for their procedures on a regular basis. So I'm like, well, do we need to start seeing people sooner? If your parents have coronary artery disease, we definitely need to see you early and start early looking for these things. And I'm like, and this is how little I knew about powerful prevention techniques at the time. I said, what are we going to do for them anyway? A stress test, really? Because I had already worked long enough to know that I had been asked too many times, I had a normal stress test 6 months ago. How did I have a heart attack? Or I had a normal stress test last year. How has this happened in a year? So anyway, fast forward, I went to every course I could find, there were a couple of other cardiologists that I worked with, as you know, that we were also on this path of, this kind of seems like we're saving lives, but then it's a Band-Aid approach after that. And so we sought out every possible answer to that we could, which has led me to then ultimately move out of the hospital and open a practice at first with one of the cardiologists, and then he went on to do more of a athletic performance and longevity practice, and I'm stuck with cardiovascular disease identification, stabilization, and reversal to try to solve this problem.
Well, thank you. Somebody should be there. All right, so your questions for
Yes.
Dr.
So,
Bryan.
who better to ask about this problem than Dr. Nathan Bryan? So, one of the things that's been on my mind lately, and I've been studying a lot, is I'll ask a more global question first, then the specific question, is about everybody wants a yes/no answer, of course. Like, this needs to be high, this needs to be low. You need this, you don't need that. But when it comes to stabilization or reversal or even prevention of cardiovascular disease, we want that LDL low in the current literature. The bad cholesterol, for those that maybe aren't familiar with the term LDL. First of all, that's starting to irritate me that there's good and bad, because am I right? That's the first question. Don't they both play a role in trying to save our life initially?
Yeah, that's right. If the body makes it, there's no mistakes.
Yes.
Right? It's part of normal kind of lipid metabolism. It's the imbalance. And now we're finding that really a standard lipid panel means nothing.
Yes, thank you.
Total cholesterol, LDL, HDL, those have no prognostic or diagnostic value.
Thank you.
You have to dig a little bit deeper because the body always responds. If you insult the body, it always responds. So a lot of these are protective mechanisms. So just because it's elevated, it'll tell you something's wrong, but it doesn't dictate that it needs to be lower. Right? You have to figure out, why is it elevated? How's the body responding? The body's responding to something. You got to figure out what that insult is, and then mitigate that. And then the body will always rebalance.
Excellent. Thank you. That settles that, and I'm so glad for that answer. So my second part to that is, then I always check the blood test oxidized LDL as well. So as I delve into that and look at all the other inflammatory markers, I'm trying to understand that process better in terms of oxidized LDL. Tell me if I'm correct, and then please elaborate. Is initially part of, again, the good guy trying to help, but then the immune system just can't. I'm talking about at the cellular level.
Right.
I'm not talking about the immune system, overall body, but that process gets broken. Something about the way that the oxidized LDL does or doesn't bind to the receptor and take care of those macrophages that are. So explain all of that to me, and is it important to check oxidized LDL, and it's more important to keep that low? That's what I've been thinking, but I don't know if that's true.
No, I think you're exactly right. So yeah, you look at lipoprotein particle size and numbers, and then certainly the oxidized particle. Because this oxidation, it could be lipoproteins that are oxidized, it could be sulfhydryl groups on proteins that are oxidized. But as a biochemist, everything is about oxidation reduction. And oxidation is a loss of an electron, reduction is a gain of an electron. So if something's oxidized, that means that it's lost an electron. And so you have to reduce that. So you have to provide a source of electrons. And that's really what antioxidants do. That's what everything we know about longevity and well-being, or, it's providing enough electrons for the cell to do the biochemistry within the body. So if you have oxidized LDL, that means the body's in a state of oxidative stress. And oxidized LDL, if you looked at other proteins, you could call it, oxidized, the sulfhydryl groups of hemoglobin. We look at hemoglobin A1C, which is a glycated, but, oxidative stress occurs on every kind of redox active biomolecule, whether it's a metal or whether it's sulfhydryl or some other amino acid. So that tells us that the body's under a lot of oxidative stress. And what's the cause of that? And then that's how you get a little bit deeper. But you have to mitigate the oxidative stress, right? So there's 3 finite responses to every insult the human body gets introduced to. It's inflammation, it's oxidative stress, and immune dysfunction. So if you look at autoimmune or immune dysfunction, if you look at oxidative stress, if you look at inflammation, those are the drivers of every disease. So it's not, you can mitigate the oxidative stress, and nitric oxide really gets to the root of all 3 of those, because it prevents overexpression of NADPH oxidase, which is a major contributor to superoxide. And these are acute phase proteins or acute phase enzymes because we need superoxide, we need oxidative stress to, kill infections, to start an inflammatory cascade for wound repair and replacing dysfunctional cells. But when it's chronic, then it leads to oxidation, oxidative stress, and in the environment we call that rust, right? When you oxidize metal, it rust. And same thing, we can rust in our body. But if we basically shut down superoxide production from NADPH oxidase, the electron transport chain of the mitochondria, if there's electron leakage, it reduces molecular oxygen to superoxide instead of ATP, the cellular energy. So we have to recouple that. And then the other major contributor is the enzyme that normally makes nitric oxide. If it's uncoupled, again, it reduces molecular oxygen to superoxide. So we've got to shut down the oxidative stress, especially if it's chronic. And then you basically normalize oxidized LDL or any other protein or target you're looking at.
Okay. And in the beginning you said, particular particles of LDL, in particular ApoB, I assume, or do you? Yeah.
No, I think those are certainly one of the most inflammatory lipid particles, and I think it's contributing to a number of different pathologies, including Alzheimer's, advanced cardiovascular disease. But really, Alzheimer's is just an advanced form of cardiovascular disease. It's focal ischemia, it's insulin resistance,
yes,
and it's diabetes type 3.
Yes.
I mean, and if we can restore blood flow, if we can improve glucose uptake and insulin signaling, then you can get to the root cause of Alzheimer's.
So does the oxidized LDL occurs in the intima, right? The layer underneath the endothelium, and so oxidized LDL doesn't play a role in damaging the endothelium. It starts its activity once.
I think it's a consequence of endothelial dysfunction and the lipid transport and the extravasation of what should be circulating molecules that extravasate through the endothelium, and then they elicit immune response, oxidative stress. You get foam cells, plaque deposition. You get hyperplasia of the smooth muscle, and that starts to occlude the lining of the blood or the blood vessel. You get stenosis, plaque becomes unstable, and it ruptures. So those are consequences of the disease, and I think that's the problem with drug therapy is most drug companies are targeting the consequence of disease instead of the cause of disease. Because if you look in any pathology, you're going to find something there, right? You find whatever you're looking for, and you target that. Like the best example is targeting the amyloid plaque and the tau tangles in Alzheimer's. There's drug companies spending billions of dollars on monoclonal antibodies against the amyloid and the tau tangles. But again, that's a consequence of disease. It's not causing the disease. So it's no wonder to me why these drugs fail and why patients don't get better on this type of drug therapy.
Right.
And it's the same thing with targeting cholesterol and LDL for cardiovascular disease. Statins were introduced in the 80s, right? And I think the American Heart Association made a statement that lowering cholesterol and targeting cholesterol would completely eliminate PCIs by the turn of the century. And today we do more percutaneous coronary interventions than at any time in the history of medicine.
Right.
So obviously, cardiovascular disease isn't getting better. In fact, it's getting worse. But yet, everybody's on a statin if you even have the slightest risk. But it's not affecting primary outcomes, or there's no primary prevention data. There's no secondary prevention data. It's the wrong target.
And 70% of people that have heart attacks have normal cholesterol levels. I don't really know the breakdown of that. I don't know their particle size, but...
No, that's right. And even if you have a heart attack and you go to the ER or you go to your cardiologist, you could have a cholesterol of 200. They're still going to put you on a statin.
Right.
It's just the standard of care, but there's no secondary prevention data on that, so it makes no sense.
Yeah. Well, I have a question about statins, but I'll hold that for a minute because back to the artery wall. You were saying earlier, so thinking about root causes, which is what you said and totally agree with. Like, obviously it's not really working throwing a statin at this, but even if it did, it's not targeting the root cause. Because there's not one root cause in most cases. Wouldn't you agree? There's multiple root causes. Maybe your diet is terrible and you do have, insulin resistance, and probably those go hand in hand anyway, don't they? You're not exercising, and there's a whole host of things, of course. But since there isn't just one thing, that's one reason medications. Most medications, I don't know of one that will work, because it's, like you say, targeting one of the pieces of this process, which may be a good thing, maybe a bad thing, might slow the disease, but obviously we haven't seen the outcomes change. So I would say top of the list are the things we're talking about at the conference this weekend in terms of root causes, decreased oxygenation, lack of nasal breathing, all the way from upper airway resistance to full-blown sleep apnea. That's what's the word I'm looking at? Continuum, sort of, but it's several different processes could be impaired, leading to low-quality oxygen, so to speak. And then the oral pathogens, of course, lack of nasal breathing fosters the environment for oral pathogens, and then oral pathogens can be transmitted.
That's right.
And then thirdly, I think on my list of what I see most often in the clinic, and you can tell me what you would put in those categories, is either insulin resistance or prediabetes. You don't know it. Insulin resistance, you don't know it. You do or you don't. Then it's ultimately going to become what we call diabetes, which whole continuum, I sort of hate that we have names for it. It's just like, this is healthy, that's unhealthy. But at the same time, we've been forced to call it something once. At least according to the American Diabetes Association, it's above 120 twice. But I see so much diabetes that it's not always 120 every morning. So anyway, we have to look at a lot of labs, look early to figure out what's going on. Even if a person looks thin, they can be diabetic or pre-diabetic for sure.
Or hypertensive.
Yes, or hypertensive, and all of that all goes hand in hand. So those would be top of my list. And if I had to give you top three, would you add to that list, or would you change that list?
No, I think those are certainly the top three. We know those are the major contributors to chronic disease. Mm-hmm. But again, there's multiple causes for insulin resistance.
Right.
There's multiple causes for hypertension and protein misfolding and oxidative stress. Mm-hmm. But again, the body always responds with these three finite responses. So if you have poor oral hygiene, and you've got gingivitis, which is an inflammation of the gingival tissue, or periodontal disease, then that inflammation becomes systemic. Mm-hmm. And then it's that systemic inflammation that shuts down nitric oxide production. It leads to insulin resistance. It leads to a loss of regulation of blood pressure and blood flow. Mm-hmm. And the same thing, if you're, some drug therapy like proton pump inhibitors, like, antiseptic mouthwash that's killing the oral microbiome. Mm-hmm. All of that, anything that shuts down nitric oxide production is what leads to the rapid progression of vascular disease. And there's a vascular component to every major chronic disease, whether it's neurological disease or liver disease, kidney, coronary disease. Mm-hmm. It's all fed by the same blood vessels. And if you if you lose the vasomotor tone and you can't dilate those blood vessels to improve blood flow to that organ when you need it, then that organ fails. Mm-hmm. So whether it's, we published in 2009 that nitric oxide is part of insulin signaling. So if the cell can't produce nitric oxide, insulin's still going to bind and lead to intracellular signaling. But if the cell can't make nitric oxide, then the terminal step in that, GLUT4 translocation, you're never going to get glucose uptake. So you're going to elevate blood sugar levels. It's going to tell our pancreas, hey, I need more insulin. You're going to secrete more insulin. Now you've got hyperglycemia, hyperinsulinemia, and that's the inflammatory cascade we see in diabetics and really any major chronic disease. Mm-hmm. So if we can restore, and what our focus is obviously I come with a very heavy bias because this is what I've done for 30 years, but if we can restore the cell's ability to produce nitric oxide, then you can complete the insulin signaling, you can improve glucose uptake, you can dilate the blood vessels, you downregulate the adhesion molecules in the lining of the blood vessels, so now you don't get the attachment of LDL and extravasation. You maintain the barrier function of the endothelial cells, and it really addresses the root cause of everything we subject our body to.
Yes, you're right. After you talk, I didn't mean at all either to reduce this down to three things, and so I definitely want the listeners to know that I'm not saying that by any means, because then once you say, okay, now we do have insulin resistance or we do have whatever, okay, then what's contributing to that? Then it gets the list gets even longer. We have to figure out the 10 things that are leading to diabetes or insulin resistance and hypertension and all the other things in your life and someone else's.
Yeah, but now with this whole microbiome project and it being completely mapped, we know that it's really maintaining a healthy microbiome that's really contributing most to the health of the human host.
Yes, agreed.
And so now we live in this, germophobic society where everybody's using an antibacterial soap.
Yeah.
People are bathing 2 to 3 times a day. We use mouthwash, use fluoride in our toothpaste. We overuse antibiotics. I mean, it's completely destroying the bacteria that live in and on our body that are there to do essential metabolic functions that we as humans can't do.
Yes, I agree.
And I think that's really the intersection of dental medicine with, the whole medical community, merging, dentists with physicians and understanding that disease starts in the mouth, and you got to address that.
I really liked what Dr. Ava said earlier, really he was talking about airway, but I think the same principle exists where in a younger person, you have these initial insults that you can mask because you're resilient still. And then as you age, you progress in this way that is unpredictable because now your resiliency is taxed, right? And so I think, you've been masking for so long that all of a sudden we have to do a whole lot of investigation. And I think that that's a main factor in kind of unearthing where the primary source originated.
Right. That's so good. And the other thing that it makes me think of, as I was also thinking when you were speaking, Dr. Bryan, is that even if you're not using mouthwashes and things that sterilize the mouth and the gut, or try to, there's no way that you can avoid insulin resistance, at least, like poor insulin glucose communication if you're eating all processed foods. But you can probably get away with it when you're younger and think it's okay.
Yes,
more so
exactly.
than the older you get, the more you
well,
feel it.
not if we all
or
get NASH early on.
Yeah, well, there you go.
Yeah, that's right.
And I'm seeing younger and younger people, absolutely, with non-alcoholic fatty liver disease, for sure.
Yeah.
It's scary, that don't even drink, or some of them very little. So we can't try to, say, oh, they're not telling you. No.
Yeah, kids getting their livers replaced, that's no good.
Oh, yeah, even kids. I mean, when I say young, they're like 20s and 30s, but still, it's too young,
That's right.
but kids.
Yeah, I think we can reconcile that, because if you look at kind of endothelial nitric oxide production with age, when we're young, we make a lot, right? Even if we, in kids that don't eat a good diet, their endothelial function is still pretty good. But the older we get, typically in population-based studies, we lose that endothelial nitric oxide production. Now we're almost 100% dependent upon the foods we eat and our oral microbiome. So where we could mask that early on because we can compensate by the endothelial nitric oxide production, if we lack that as we age and we don't eat a good diet and we're killing the microbiome, now we're completely nitric oxide deficient, and that leads to the onset and progression of disease.
Are there any patients that you've evaluated that don't have that aspect as they age, or is that just an artifact of the inflammaging that we're now used to seeing?
Well, it's certainly, if you look at the average population and you look at, but it doesn't have to be the case. I'm always kind of the N=1 guinea pig experiment, right? But I turned 50 in November, and I've got the vascular age of a 32-year-old. So, and it's not that I don't think my genetics are superior, but it's hard work. I get up every morning, I exercise, I try to eat a balanced diet in moderation. I watch what I put in my mouth. I grow my own food. I raise my own beef. I don't take drug therapy. I'm not on any prescription drugs. So we can shift.
But do you name your cows?
No.
Okay.
There's too many.
Get too close. Don't get too close.
Yeah, you can't develop a personal relationship with them when they're on your plate.
Plus, you run out of names. He has a lot of cows.
To get through the alphabet.
Yeah.
But no, I think what we're finding is that, to the contrary, we're seeing 20 and 30-year-old kids, as we call them, that have a vascular age of a 60-year-old.
Yeah.
So you can accelerate or decelerate that entire progress, and we're trying to figure that out as how do we maintain the function of that enzyme, how do we maintain the diverse oral microbiome, and how do we feed the human body and the bugs what they need to repopulate and do their job.
We've talked about genetics a couple of times. It makes me want to ask you a couple of things, and one is, I believe, and I'm sure you do too, that people feel like they've been dealt a bad hand, or like they've been something. I know they're genetic defects. That's a totally different category. But a lot of people say, I'm not going to worry about what I eat because I have terrible genetics and it's going to happen to me anyway, which is an awful way to look. But I just want everybody to stop for a minute and realize that your genetics, not one genetic test or one
That's right.
genome, one DNA is going to lead to a heart attack. I mean, you have control over that. You really do.
Well, it's the blueprint,
Yes.
right? But it doesn't necessarily mean that you're going to express those. So now
Yes.
this, 20 or 30 years, maybe that was a viable argument. But today,
Yeah,
through
it's-
epigenetic and being able to turn genes on and genes off by what we do, what we eat, you can't use genetics as an excuse anymore. Unless you have an inborn error in metabolism, you're born with some
Yes.
genetic defects. But these single nucleotide polymorphisms, yeah, they may increase your susceptibility or risk of developing that, but you have complete control over it.
Yes. And I love testing, and now we can test that. I know we'll look back in 2 years or 20 years and go, that was a very rudimentary test, but we have ways to
Yeah, at least you know.
test it now.
Exactly.
You know what you're up against.
Yeah.
Yeah, and know if what you're doing lifestyle-wise is slowing down the aging process. And I love testing because we can really see what's going on inside the body. Because you can see, actually, a lot of times it's the healthiest person on the block that has the heart attack. I can't tell you how many times I've heard that. He was the healthiest guy in church, or she ate better than any of us, or whatever. So you can't look at somebody
That's right.
and know. And sometimes you get a lot more information by looking on the inside with these tests. But
For sure.
the other thing I wanted to ask you was about, do statins, in your opinion, and maybe this isn't a fair question, but you and I both do not like pharmaceutical medications in general. There are a few that have a role, but we've gotten away from telling the patients about the risk versus benefit
Yeah.
ratio, educating them and letting them make a decision. Anyway, that's another podcast. But my question about statins is, if I do use it in an incredibly inflamed, high-risk individual that's sort of getting close to, like maybe I've just seen them initially and we're
Yeah.
trying to turn these things around, all these complex contributors that we talked about. Not complex, but it takes a little while to turn that around. Then I will put them on a statin, lowest dose possible. It doesn't take much. That's another thing.
Yeah.
We're
And the
prescribing.
half-life of these drugs are several days.
Yeah, I don't do anybody ever any more often than every other day, and very tiny dose. And I say this is temporary until we can get the blood work under control, take a look at your arteries again, make sure we're going in the right direction. And this isn't for life. But do you think that plays a role? I mean, because of the data that I've seen on reducing inflammation as well, and does it do anything with oxidation?
Yeah, I think, at a high-risk patient where they've got elevated myeloperoxidase, they've got vulnerable plaque, I think at that you got to throw whatever the data indicates you can to prevent an acute event. But I think that the therapeutic benefits of that isn't lowering your cholesterol or lowering your LDL. It's the pleiotropic effects on kind of the acute anti-inflammatory effects of statin. But again, it's risk benefits. So in that particular patient, probably the benefits of that are going to outweigh the risk. But in the general population, what are the benefits of a statin? There's none.
Right.
The primary prevention data is not there. The secondary and tertiary prevention is not there. Okay, what are the risks? Myalgia, diabetes, even their mitochondrial toxicants, increased risk of cancers. So in the general population, if you're looking at the risk, where there's no benefit of preventing heart attack or vascular disease, but you've got an increased risk of muscle cramps and pains and diabetes and cancers. I mean, to me, that's a very simple quotient, right? In the
Absolutely.
favor of you don't take it.
Right. Yeah.
So
Totally
yeah,
agree,
I think, but
totally agree.
there's obviously, it's probably the exception instead of the rule. But in those patients, I think, you got to give them whatever is clinically proven to kind of mitigate the inflammation and prevent that plaque from rupturing and having a heart attack.
All right. Do you also think that the same is true for chlorhexidine?
Yeah, no, I'm not against. If I've got an infection, I want an antibiotic.
Yeah.
But I think
Excellent.
you choose the right therapeutic approach, but then you have to kind of restore and rebalance the damage that you cause. I think if you got a pathogen overload, you got to get rid of it. If you've got an infection, you got to get rid of it. But then give the body, build back the foundation, and hopefully prevent that from happening again.
Yeah.
But daily, no, I don't think it's risk benefit.
And long-term use, that
Oh,
and
yes.
statins and most everything. Like the body just doesn't work that way,
Right.
where you're going to give it something, particularly something strong like a statin or chlorhexidine, and just we're staying on it the rest of our life.
Yeah. Well, the body, to me, the human body doesn't make mistakes. It always responds. And so drug therapy for the past 150, 200 years, it's a synthetic compound that inhibits a biochemical reaction. And there's consequences to that. And so our body makes cholesterol because our body needs it. And if we give a compound that inhibits cholesterol synthesis in the body, there's consequences to that. And so there's a reason our body makes it. If we're not getting enough from the diet, then our body has to make it. And we need cholesterol to make vitamin D. We need cholesterol to make testosterone and estrogen and a lot of hormones. And we need cholesterol in our cell membrane so we can maintain that fluidity, so we get intracellular signaling, and the outside of the cell can talk to the inside of the cell. And if there's no cholesterol or you get it below 200, then you lose that membrane fluidity, you lose cell signaling, you develop insulin resistance, become low in vitamin D, low testosterone, hormone imbalances, and I mean, geez, it's the start of an entire cascade.
Right.
Yeah.
So it's no wonder why Americans are sick. Everything we do, if I wanted to make, and I joke about this, but it's really no joke. If I wanted to make you sick and chronically dependent upon drug therapy, I would advocate that you use mouthwash every day. I would give you an antacid, a proton pump inhibitor. I would get your cholesterol below 200. And that sets the stage for a patient that's going to be dependent upon pharma for the rest of their life.
And honestly, very little can overcome that. I mean, if you say, well, but I exercise or whatever. I mean, you cannot overcome that.
Yeah, if you can't make stomach acid, you can't absorb selenium, B vitamins, magnesium, iodine, you become nutrient deficient.
Yeah.
Using mouthwash, you're killing the microbiome, and follow the government guidelines on diet.
Yeah.
Eat a lot of grains and sugars and very little red meat.
Even Mediterranean, it bothers me. The whole bottom or second rung is grains.
Yeah, well, it makes no sense.
Yeah.
But that's what we're up against.
I think we're out of time.
Oh,
aren't we?
I mean, there's so many
questions.
No, we can always come back.
That sounds good.
No, this is fantastic. I think this is conferences like this, bringing all of us together, getting us all in a room, and having this dialogue is the most important piece to the puzzle that we're in right now. So this is a great start.
Yeah, me too. The collective mind.
Yeah.
Thank you.
Yes,
Thank you.
Pleasure.